Hello everyone, welcome to the second workshop. In this workshop, pre-case will be presented. It is about what you should know before ISE. Let's look into pre-industrial skills event. At this workshop, we will cover overall background knowledge that can help understanding the case. We will walk down to what is TNBC, brief introduction to cancer drug, difference between chemical drugs and biopharmaceutical drugs, and benefits of cocktail therapy. Okay, let's start with TNBC. Some of you might wonder what TNBC is. TNBC stands for triple negative breast cancer. It occurs to those who do not have estrogen or progesterone receptors and who do not express enough amounts of HER2 protein. Therefore, common breast cancer treatments are not effective for TNBC patients. TNBC accounts for 16% of invasive breast carcinomas. Also, it accounts for about 5% of all cancer-related deaths every year. It has been one of the lowest 5-year relative survival rates. Now, let's have a look at what are the challenges that TNBC treatment faces. As mentioned earlier, it differs from other breast cancer types. First of all, it is common in young age group. Secondly, there are limited treatment options because it is a heterogeneous disease. Therefore, common breast cancer treatments are not effective, and there are no wonder drugs to magically treat TNBC patients. Lastly, it has a worse prognosis. Therefore, diagnosis works in advanced stage, which makes the survival period shorter and recurrence risk higher. Now, let's see what current TNBC treatments are being used. If TNBC is found in earlier stage, which means that the cancer cells haven't spread to distant sites, chemotherapy with the best response for each patient depending on disease progression or toxicity are treated. Anthracyclines, taxanes, and platinum-based carboplatin are treated as chemotherapy. Surgery, radiation, and adjuvant chemotherapy could be also conducted. If TNBC is found in metastatic stage, which means that the cancer cells have already spread to distant sites, treatments can vary whether patients are in slow progression, in rapid progression, or responsive to PD-L1. For slow progression, chemotherapy is treated. If patients have BRCA or also SAD at BRCA mutation, poly-ADP reverse polymerase inhibitors are used. If patients do not have non-BRCA mutation, anthracyclines, taxanes, capecitabine, eribulin, and vinorelbine are used. Also, for rapid progression, chemotherapy is treated. Generally, combination of a nanoparticle albumin-bound paclitaxel and carboplatin or combination of gemcitabine and cisplatin are used. For those who are responsive to PD-L1, immunotherapy can be treated such as antibody-drug conjugate and immune checkpoint inhibitors. In this slide, it sums up the traditional care that I just explained. Patients without BRCA mutations are treated with sequential single-agent chemotherapy such as anthracyclines or taxanes and other chemotherapy agents which are best fit to each patient. Patients with BRCA mutations are treated with poly-ADP reverse polymerase inhibitors like olaparib. Patients with rapid progression are treated with combination of chemotherapy such as nanoparticle albumin-bound paclitaxel and carboplatin or gemcitabine and cisplatin. As new strand of care, there are monotherapy or combinations of immunotherapy. Most well-known immunotherapy agents for TNBC treatment are TROP2 targeted antibody drug conjugate such as sacituzumab govitecan, or PD-1 targeted immunotherapeutic agents such as pembrolizumab, atezolizumab, or nivolumab. There are various drugs for cancers, from chemical drugs to biopharmaceuticals, which are cytotoxic chemotherapy, hormone therapy, and immunotherapy. Examples for cytotoxic chemotherapy are alkylating agent, microtubulin inhibitor, antimetabolite, topoisomerase inhibitor, miscellaneous antineoplastics. In hormonal therapy, there are steroid, anti-estrogen, anti-androgens, LHRH analogs, and anti-aromatase agents. Immunotherapy include cytokines, vaccine therapy, immunomodulatory drug, differentiating agents, and more. Let's look into TNBC chemical drug examples. First, topoisomerase inhibitor. Topoisomerase inhibitors prevent realizing of DNA strands and maintain single-strand breaks. Second, alkylating agent. Classical alkylating agents interfere with DNA replication by cross-linking DNA strands, DNA strand breaking, and abnormal pairing of base pairs. They exert their later effects on cells throughout the cell cycle. Platinum-containing compounds alter the cell membrane transport systems and suppression of mitochondrial function. Cyclophosphamide is an example of alkylating agent. Third, microtubulin inhibitor. Microtubulin inhibitors bind to microtubulin proteins during metaphase, causing mitotic arrest. The cell cannot divide and dies. This group is mainly cell cycle phase specific for M phase. As an example, there is a paclitaxel. Fourth, antimetabolite. Antimetabolites interfere with DNA and RNA synthesis by acting as first metabolites, which are incorporated into the DNA strand or break essential enzymes so that DNA synthesis is prevented. Fifth, anthracyclines. Antitumor antibiotics, also called anthracyclines, interfere with RNA and DNA synthesis. Most drugs are cell cycle non-specific but tend to be more effective against rapidly dividing cells. Doxorubicin is one of anthracyclines. Now, let's look into examples of biopharmaceuticals especially used for TNBC treatment. There are antibody-drug conjugation and immune checkpoint inhibitors. First, antibody-drug conjugate. Antibody-drug conjugates, as known as ADCs, are highly targeted biopharmaceutical drugs that combine monoclonal antibodies specific to surface antigens present on particular tumor cells with highly potent anti-cancer agents linked via a chemical linker. A linker that is stable in circulation but releases the cytotoxic agent in target cells. Therefore, ADCs kill target cells with reduced systemic toxicity. Sacituzumab govitecan is one example of ADC. Alright, now let's move on to immune checkpoint inhibitor. Immune checkpoint inhibitor. Immune checkpoint inhibitors are a type of immune therapy. They block proteins called checkpoints made by some types of immune system cells such as T cells and some cancer cells. These checkpoints help keep immune responses from being too strong and sometimes can keep T cells from killing cancer cells. When these checkpoints are blocked, T cells can kill cancer cells better. Pembrolizumab and atezolizumab are examples of immune checkpoint inhibitor. Now, let's talk about what chemical drugs and biopharmaceuticals are. Chemical drug is literally a chemical-based drug as known as traditional pharmaceutical substances. Chemical substances synthesized from non-living chemical reagents to affect or alter the physiology when taken into a living organism to prevent and cure diseases. On the other hand, biopharmaceuticals are the type of drugs which are pharmaceutically manufactured and extracted or semi-synthesized from biological sources like humans, animals, or microorganisms by utilizing biotechnology. Each of chemical drugs and biopharmaceuticals has advantages as treatments. For chemical drugs, which are small molecules, they are widely used to pre-cancer surgery, post-cancer surgery, micrometastasis, last-stage cancer symptoms relief, and more. And chemical drugs are relatively stable and mostly non-immunogenic. Also, biopharmaceuticals got great advantages too. First of all, biopharmaceuticals have fewer side effects than chemical drugs because of their specificity. Additionally, biopharmaceuticals are customized treatments for individual diseases. Also, gene therapy is one of biopharmaceuticals which can replace defective genes with healthy genes. While chemical drugs have been widely used as traditional drugs, we should focus on biopharmaceuticals. These graphs and lists from recent studies represent needs for biopharmaceuticals have been massively increased. Now, let's deep dive into characteristics breaking down to a variety of perspectives. From a selectivity and safety perspective, chemical drugs cause side effects or toxicity because they usually bind to various off-target sites. However, they are mostly non-immunogenic. Meanwhile, biopharmaceuticals are less toxic because they are highly specifically structured, which can bind to specific targets. However, they are sometimes immunogenic. From cell permeability perspective, chemical drugs bind to various extracellular or intracellular domains. However, for biopharmaceuticals, intracellular domains and blood-brain barrier are inaccessible because they are mostly larger than 600 Dalton. In terms of delivery, chemical drugs are suitable for oral delivery, while biopharmaceuticals are nearly all biologics orally inactive. It is because of their intrinsic instability and high molecular weight. Therefore, mostly invasive delivery work or alternative non-invasive technologies are treated as well. Let's look into how they act at the distribution level. Chemical drugs get distributed by the blood circulation, which led to achieve peak concentration quickly. Biopharmaceuticals get distributed by both blood circulation and a slower lymphatic system. Therefore, they have a longer half-lives than chemical drugs. As biopharmaceuticals have limited volumes of distribution, it takes slower to get to peak concentration. This position is also one of the important factors as drugs. Disposition of chemical drugs are metabolized by cytochrome or non-cytochrome renal filtration and fecal excretion. On the other hand, biopharmaceuticals are directly affected by receptor drug binding, protease, and peptidase. If a patient takes multiple drugs, chemical drugs are prone to drug-drug interactions. However, biopharmaceuticals are less likely prone to traditional drug-drug interactions as they act like endogenous substrates. Generally, chemical drugs are provided at a low price because of low production source, process, and device-affected variation. On the other hand, biopharmaceuticals are provided at high prices due to high production source, process, and device-affected variation. Per attribution, chemical drugs have a high rate of attribution, but biopharmaceuticals have relatively low rate of attribution. After patent expired, there is severe competition from chemical genetics as chemical drugs. However, biopharmaceuticals have less severe competition from biosimilars. Lastly, from a development perspective, chemical drugs go through simple drug discovery and development processes. whereas biopharmaceuticals go through more expensive and complex drug discovery and development processes. While looking through all these drugs, you might wonder, can't we use more than one drug? The answer is yes. Cocktail therapy is exactly that, a mixture of drugs used to treat a particular condition. At cocktail therapy, optimal combination strategies are designed with complementary mechanisms of action. It creates additive and synergistic activities such as better clinical outcome, better PK properties, advanced patient adherence, target-directed selectivity, and more. It can also minimize cancer cell resistance. Combination of immune checkpoint inhibitors and chemotherapy is an example of cocktail therapy. From this therapy, it takes advantage of both. Immune checkpoint inhibitors prevent overactivation of immune system. Chemotherapy directly kills tumor cells, restore immunosurveillance, modulate tumor microenvironments. However, each ICI and chemotherapy has their own downside if they are treated individually. Only a minority of patients respond to ICIs, and it is non-immunogenic to cold tumors. Chemotherapy causes toxic side effects and development of resistance to chemical agents. Following slide will show how the combination treatment got over these. This chemotherapy and ICI combination is durable and improved clinical response. Chemotherapy helps overcome ICI resistance by converting cold tumors to hot tumors. It widens the therapeutic window and is effective in greater spectrum of patients. Also, ICI helps enhance chemotherapy clinical outcomes by preventing immune overactivation to be higher efficacy of chemotherapy and to have less side effects. Thank you for attending the workshop of what you should know before ISE. We hope all you get enough information from this workshop. Thank you.